Okay, so let's share the 3D anatomy. So first we'll be going for the bony anatomy, then we'll be coming for the other structures. So if we look at this part of the bone, that means towards the lateral and posterior part, we have mainly three bones here as well. In the lateral part, previously we have discussed, there is a in lower part of the humerus there is a rounded structure which is known as the capitulum, where attached the head of the radius and around which we have the annular ligament to secure it. Next, in the posterior side, we have the olecranon process. This we have discussed yesterday. So, in posteriorly, you can see there is a fossa in the humerus also, that is known as the olecranon fossa. So, pathologies in the lateral part mainly involving either this portion, that means the lateral collateral ligament, and also the common extensor tendon, because all the extensor muscles of the hand is taking origin from close to this part that is known as the lateral epicondyle. In the most upper part, there is another muscle which actually not in the epicondyle but in the supracondylar ridge, that is basically the extensor carpi radialis longus. So, extensor carpi radialis longus actually is not a part of the common extensor tendon because its origin is not at the same place as the other muscles. Okay, most of the other muscles coming slightly below from the lateral condyle and below, whereas only a small portion of the extensor carpi radialis longus is a part close to the lateral epicondyle. Rest takes origin from the supracondylar ridge. If we look at slightly medial to this muscle, we'll be looking at the brachioradialis, and below underneath we'll be having the supinator. So supinator also taking origin from this area. So let us go for the capsules and ligaments of the joint. So if we look at, there is a ulnar collateral ligament, that's a strong ligament, and that is also known as the here we are having not the ulnar collateral ligament. Ulnar collateral ligament we have discussed in previous class. So here we are having the radial collateral ligament, and if we have the anterior part and the posterior part, and also we have a ligament that is known as the annular ligament. Okay, and here we are having the common extensor muscles. So let's go for the common extensor muscles. So if we look at the muscles, so here we are having the anatomical map. So from the previous knowledge of the anterior elbow, we know this muscle is the brachioradialis. So let us hide the brachioradialis first so that we can see the other muscles. So we are hiding the brachioradialis. And as we have hidden the brachioradialis, this muscle is the extensor carpi radialis longus. So we can see the extensor carpi radialis longus, and its most of the origin is just above the lateral epicondyle near the supracondylar ridge. Now, if we hidden this muscle, then we are seeing two muscles taking part of this portion of the lateral epicondyle. So one is this, the extensor carpi radialis brevis. Remember, in most of the cases in lateral epicondyle, it is basically, though we say it's an epicondylitis, but actually it is the tendinosis of the extensor carpi radialis brevis tendon. Sometimes there could be injury or tear, sometimes there could be possibility of calcific tendinopathy as well involving this extensor carpi radialis brevis muscle. Slightly anterior to it remains the supinator. Remember, the ulnar nerve pierces between the two heads of the supinator, and there is an area where ulnar nerve can get compressed into the two heads of the supinator. Now, if you look at this muscle, that is the extensor carpi radialis brevis, the next muscle is the extensor digitorum. Remember, when we look at this point, we usually see a scorpion tail appearance. And what is the scorpion tail appearance? It is basically the tendon of the extensor carpi radialis brevis muscle, which is taking origin at this point. And if you look at this portion, usually the third muscle, that is the extensor digiti minimi, is usually not seen. To see extensor digiti minimi, we have to go a little down where the muscle bulk is comparatively larger and can be seen more clearly. So at this point, we will be able to see most of the extensor carpi radialis brevis, and then we will be seeing the extensor digitorum. In between, we will be taking the short scorpion tail appearance, and just after it, we will be able to see the extensor carpi ulnaris. As we go slightly down, then we will be able to see the extensor digiti minimi portion of the muscle as well. So this remains in the anterior part, in the lateral part, whereas in the posterior part we have a big muscle, that is the triceps, which having all three heads, they are combined together into the triceps tendon, and that attaches with the tip of the olecranon process. So here there could be possible pathology like triceps tendinopathy. There could be also injury to the triceps tendon, and another condition might happen that there could be an impingement syndrome or effusion in the olecranon, this area as well. Okay, so sometimes there could be effusion in the olecranon fossa. Basically it's the shoulder and elbow joint effusion that can be seen from the posterior side. So these are the things we have to know. So let's go back to the presentation. So anatomy, I think you have understood, but before that, one part anatomy I have missed, so let's complete that first. It is the nerve anatomy. Here there are a number of cutaneous nerves that cannot be seen clearly, so we are not going to discuss that much of the cutaneous nerves, but most important part is the radial nerve. So let us hide the cutaneous nerve of the forearm. Here also we are having the posterior cutaneous nerve. Now, if we hide this brachioradialis, then underneath we can see the radial nerve. So this is the radial nerve. Usually just above the elbow, we see radial nerve as a single nerve, but as we come down, usually it is split into 2-3 branches, 2-3 smaller branches. And as we go down, we'll be able to see one of those larger branches, one goes anteriorly, and this becomes the radial nerve which goes superficially, and then we can see it again at the wrist near the first compartment. Whereas here, if we look at, there is another branch, that is the deep branch that goes into the supinator muscle, and then it goes as a posterior interosseous nerve. So it is going for the posterior interosseous nerve. Remember, posterior interosseous nerve is mostly a motor branch, whereas the anterior branch of the radial nerve is usually the sensory part of it. Okay, so we have understood the nerve as well. Let's come back to the presentation and let us discuss a little. So what are the common disorders affecting the lateral and posterior elbow? If you look at the lateral elbow, common disorders includes the lateral epicondylitis, which is also known as the tennis elbow, which is quite common and far more common than the medial epicondylitis. Then we have the radial tunnel syndrome. Then we have the posterolateral instability of the radioulnar joint. There could be possibility of the radial head fracture, and also there could be osteoarthritis or chondral lesions. If you look at the causes for the posterior elbow pain, the common causes includes the student's elbow, which is basically a superficial bursitis, which remains very superficial just above the olecranon, and between the skin there is a bursa. So if the fluid accumulates because of the repeated friction, which is common only among the students because of the long writing, that is known as the student's elbow or olecranon bursitis. There could be associated problem with the triceps tendon, which is known as the triceps tendinopathy, and there could be, as I've already told, there are soft tissues which might be impinged in the olecranon process, and that is known as the posterior impingement syndrome. There are chances of the olecranon fracture and as well as the osteophytes and other loose bodies or arthritis, so that could be the cause for the posterior elbow pain. Now first let us discuss about the lateral epicondylitis. As I have already told, the lateral epicondylitis is also known as the tennis elbow. It's a painful condition involving the tendon that attaches to the lateral epicondyle of the humerus, and common in adults between the 30 to 50 years of age. Now in the anatomy also I have told that it is mainly tendinitis of the extensor carpi radialis brevis and other wrist extensor. Pathophysiology includes the microtears, which is involved because of the repeated injury to this tendon and associated with the degeneration of the tendon, and it occurs at the place where it attaches close to the lateral epicondyle, and repetitive strain is usually the cause, and also it can caused as a part of the overuse syndrome because of the sports and repetitive occupational tasks. For example, painting, carpentry, etc. And poor technique and poor ergonomics and poor training is one of the causes that can actually give rise to this condition. And there could be associated factors like sudden increase in activity rather than the normal, and also it can be caused by the age-related degeneration. Now, what are the symptoms? So, among the symptoms, first of all, there would be the tenderness around the lateral epicondyle of the elbow. There could be pain that is aggravated with the motion. There could be weakness in the reduced grip strength, and gradual onset symptoms typically develop slowly rather than the single traumatic event. So now coming to the ultrasound guided demonstration of the common extensor tendon on the lateral ulnar collateral ligament. Okay. And also the radial collateral ligament. We'll be seeing all twisting together. Chinmada?
Yes. Yeah, Diljit, first I have to show the lateral side, no, common extensor tendon. You are muted.
Common extensor tendon, radial collateral ligament, and also the lateral ulnar collateral ligament.
Okay.
Doctor, last session you didn't show us the muscles that involve in the common flexor tendon.
Okay, I'll show it, no problem. Share. Okay, I think all of you can see the screen, isn't it? So I'm showing the common extensor tendon and its constituents. Okay. So you can see that hand is prone, forearm is prone, and elbow is more or less 90-degree flexed. Okay, in that area, I am putting the probe in a long axis manner. So this is my probe orientation. This is my probe orientation. Of course, my hand is blocking a bit, but that is, so we cannot do anything much. Okay. So this is my probe orientation. This is in a long axis of the common extensor tendon. So what I am seeing here, I am decreasing the depth a bit. Okay. So this is the common extensor tendon. So this is the lateral epicondyle. This is the condyle. This part is joint. This part is radial head. Of course, this is the radial shaft. Okay. So as this part is the joint area, so we can understand if there is a ligament that will be just above the joint. That means in this portion that will be the ligament area, and then of course above the ligament, this above portion will be the tendon. So simply if we make one point here and one point here, so same as the medial side, if we make a 50% line here, so I mean this 50% is for the tendon, this your ligament part. Okay, that is the ulnar collateral, radial collateral ligament. Okay, radial collateral ligament this side, this is the ligament part. Sorry, this part is ligament part, and this part is tendon part. This is the common extensor tendon. Okay, so here if we try to see it very carefully, then you will find that there is a fibrillar structure. in the upper part. This part, there is a fibrillar structure which is going inside the muscle, and gradually it is becoming the muscle here. Okay, so let us see you can perceive this part or not. So see, this is the fibrillar structure. This is the fibrillar structure, and ultimately it is going in the this part, in the upper part of the tendinous area. So this is the continuous fibrillar structure. Now, where from this fibrillar structure is coming? This fibrillar structure is mainly coming from the ECRB. This is a ECRB tendon. Okay, so this ECRB tendon is mainly responsible for the lateral epicondylopathy, mainly the tennis elbow. If there is a rupture and all, mainly the ECRB tendon is affected. But here it is not only made with the is ECRB tendon. There are 3 other tendons. So let us see in a short axis manner. So first, say I put in this joint area in the middle part, and I am making it in a short axis. So as soon as you see this rounded structure, we know that this is the radial head. Okay, if I go down, then of course this will be the radial neck. Okay, and this part is radial head. If I go a bit above, so this is the joint area when I'm not seeing any bone, and then I'm going up, then this is the condylar area of the humerus. Okay, lateral condyle. Then if I go up, then this is the epicondyle area, and it is the insertion of the common extensor tendon. Now, if I want to see the short axis form of common extensor tendon, what are the muscles? So first, let us see in this area. So first you come distally from proximal side. When you come distally and proximally, you can see one scorpion tail appearance. This is the scorpion tail appearance. Okay, this is the scorpion tail appearance. I can keep the hand a bit more extended. Okay, I can keep the hand a bit more extended, and you can see that this is the scorpion tail appearance. So this scorpion tail appearance is nothing but the ECRB tendon. Okay, then if I go a bit more distally, then I can see this part of the muscle is coming here. Okay, so just remember where you see
and it is hanging.
Maybe your internet connection is slow. Everyone is getting this. I mean, is there any problem in transmission?
No, we can see it.
No, it is all right.
Can you show the scorpion tail once again, sir?
Yes, scorpion tail. So just as soon as we start from the lateral epicondyle, so this is the lateral epicondyle area, then I'm just coming down. As soon as I come down, I see this scorpion tail. So with the different position of the hand, this scorpion tail can be seen here also, can be seen at this point also. So as soon as I locate the scorpion tail, this is the scorpion tail. Okay, this is the scorpion tail. So as soon as I locate the scorpion tail, I can understand that this part is ECRB. Of course, medial to that, this part will be ECRL. But belly of ECRL and ECRB, it is a bit difficult to distinguish because ultimately the muscle fibers are very similar. So anyway, this as soon as you find the scorpion tail, you know one side is ECRB, and what is another side? This is the extensor digitorum. Extensor digitorum. So this much we can understand. Okay, after that, so this is the scorpion tail, one is extensor digitorum. As soon as I have understood that where is the extensor digitorum, I will go a bit down like this. So in this area, I can see actually 3 bellies of muscle. One is this, one is this, and one is this. Okay, this is the extensor digitorum, as I told you. Extensor, this is digiti minimi. and this is extensor carpi ulnaris. Okay, and another muscle you will be able to see as soon as you see the head of the radius, you will see one muscle here. So which muscle is this?
Supinator.
Supinator. Okay, so in this way we can identify all the muscles. Please see again. First point is just move your probe up and down and find the radial head. As soon as you find the radial head in this rounded structure, even the articular cartilage above it, you try to find out the scorpion tail. As soon as you find the scorpion tail, you understand that this is ECRB. That means this part, the extensor digitorum, must come. Of course, this is also a part of extensor digitorum, this small part. But if I go a bit more, then I can see more distally, then I can see extensor digitorum. This is extensor digitorum. After that, a small muscle comes. This is digiti minimi and this is carpi ulnaris. And this muscle is nothing but second layer, which is coming above the head of radius. This is the supinator muscle. Okay. So these are the muscles. Now, if I again from short axis, now focus on the ECRB. Focus on the ECRB tendon, this scorpion tail. Okay. Now you will see that this is the area, scorpion tail. I mean, this is the area when it is going to make the common extensor tendon. I am making it a long axis now again. And as I showed you in the long axis, now actually it is moved. So this is the common extensor tendon. So this is the long axis of common extensor. I mean ECRB. This is the long axis of ECRB, part of common extensor tendon. So this fibrillar structure. Okay, this fibrillar structure. And this is the same thing when we are seeing in short axis, we will be finding it as a scorpion tail. So this is the scorpion tail. I think you have understood the steps. Okay. In a when you understand when you want to see all the constituents of the common extensor tendon, first head of the radius, then scorpion tail, then ECRB, common. This is extensor digitorum, and then you go distally to see another two muscles. This is the digiti minimi. This is carpi ulnaris, and of course this is the supinator. Okay. So this is the extensor side. And ligament also, you have already seen that this ligament also you have already seen that when we are seeing the common extensor tendon, the okay, so this one. So first, just near to the joint, this part is near to the joint. So this part is nothing but the ligament. This part is nothing but the ligament. So this is the radial collateral ligament area. And this is not same as the upper part. Upper part is the common extensor tendon. Okay. One more thing. That day I did not show you the muscle of the common flexor tendon, constituent muscles. So just I show you this.
Sir, what about the annular ligament here?
Which one? Which one?
Annular ligament.
Annular ligament. Annular ligament already. Okay. Just head of the radius. Thing is that we need a more high frequency probe. This area, this is the annular ligament. This is the annular ligament. You see, if I hold it in this way, okay, if I hold it in this way, then you see that this part is different and this part is also similar to this. Okay, so this part is nothing but annular ligament, just head of the radius and above that, and this part is your radial collateral ligament. So this is actually, we have to, if we see with the much more high frequency transducer, then of course we will be able to see this in a much better way. But still, we can understand that this is the area for annular ligament, just overhead of the radius. I think you can perceive, no, this is a different type of tissue. This is a different type of tissue, not the upper one. Okay, so just see. So this is the annular ligament part. Even in the short axis also, we can see actually. So this lower part, this lower part is the annular ligament. This lower part is the annular ligament. Okay.
Yes, sir.
Okay.
Okay, got it.
Okay. I'm going in the flexor side. So in the flexor side, so I'm just increasing the depth a bit. So as last day, I showed you the common flexor tendon, a bit of like this. Yeah. So from here, so we know that one is pronator teres. I am putting in this way, and then so one when I am seeing the lower end of the humerus. Okay. So yeah. So lower end of the humerus. This is lower end of the humerus. Now this is the pronator teres. This is the pronator teres. Just a minute. So this is the pronator teres, this muscle. Okay, you can understand that this is the between, this is brachialis and this is the pronator teres muscle. So I am going a bit down now, distally I am going. So when I am seeing the pronator teres, so what other muscles should come here? One thing is here, if you see flexor carpi radialis this side, then palmaris longus, then flexor carpi ulnaris. And below that, there is the flexor digitorum superficialis. Profundus is also there, but profundus is not a part of common flexor tendon. So first three tendons, and then below we will see the common flexor digitorum superficialis. Okay. So here you have understood that which one is pronator teres, this one is pronator teres. Okay. So now I have to find some other the other muscles. Okay. So first thing, I will go, I will just locate the median nerve. So this is the median nerve, I mean median vessels, of course. So here, when I'm going down, so we can see, just a minute. Okay. So this is, just locate this area. So here, so this is pronator teres. This is one muscle. Okay. I don't know the name at present. This is one muscle. Okay. This is second muscle. And this is one small muscle. I can, if I go down, suddenly you will see this muscle, this area will become smaller. So it has become a tendon here. When I'm going up, it is coming like this. Okay. So you see that where my arrow is, this is becoming smaller and this is becoming bigger. Okay. So this is one way of understanding that this muscle is nothing but palmaris longus. So this is the palmaris longus. So as soon as you find the palmaris longus and tendon of palmaris longus, you can understand all other muscles. So this muscle is nothing but flexor carpi radialis. This muscle is nothing but your flexor digitorum superficialis. This is palmaris longus, and this side will come the flexor carpi ulnaris. Okay. So while coming distally, you try to find out, always locate this part. That one muscle, it looks like it is just becoming a tendon. This one, this movement, this part, you just locate. So as soon as you located this, palmaris longus is like that. It becomes very small tendon. So as soon as you located the palmaris longus, then so this part is nothing but the palmaris longus. This side we have already seen the pronator teres. So this is another muscle, flexor carpi radialis, and this is the big muscle. I mean, not with this part. So this is the flexor digitorum superficialis, and this side, of course, I have to show. So this part is flexor digitorum profundus, and of course this side it is there, flexor carpi ulnaris. Just try to see again. Okay, so this is the pronator teres muscle. You can understand brachioradialis, pronator teres. Now I am just rotating my probe in this way so that I see the muscles of flexor muscles. So in this hand, I am rotating the probe. Okay. So we have already looked at pronator teres. So what are the other muscles? 1, 2, 3, and of course, fourth is this side. So here we can see that this muscle has become smaller. As soon as we see that this muscle becoming smaller, so we know that this is palmaris longus. So this is palmaris longus, this is flexor carpi radialis, this is superficialis, this is profundus, and this side is the flexor carpi ulnaris. Okay. Between superficialis profundus, there is a plane. In this plane, you can see two nerves. One is your median nerve, one is your ulnar nerve. This is the ulnar nerve. Okay. And this side, of course, median nerve will be there. So this side is, this is the median nerve, ulnar nerve. Okay. So understand, the pulmonary, locating the palmaris longus is very much necessary. So this is the palmaris longus. Okay. Understood, no? Flexor muscle,
Yes,
5
sir.
muscle. Okay. So I think it's okay. So Devjyoti.
Yes, so let's continue. So let us see the diagnosis for the lateral, this part, that is the diagnosis. So what is common diagnosis? First, it is the physical examination, among which one test we commonly perform, that is known as the registered wrist extension test, also known as the Cosen's test. So previously in the last class, you have seen how we are actually putting it. So we are in the reverse Cosen test. What we are doing for the common flexor tendon, we are asking the patient to flex the arm and we are registering. Flex the wrist and we are registering. Here you have to do the opposite. So ask the patient to extend the wrist while keeping the elbow stable at 90 degree, and now the examiner will be registering the extension and the patient will try to do the extension. So in this way, what will happen, there will be more pressure over the common extensor tendon, and that will reproduce the pain of the lateral epicondylitis. Imaging, X-ray usually do not show much abnormality except where there are bony abnormalities are there, so that can show. But in most of the cases, ultrasound and MRI is for the lateral epicondylitis. In most cases, you have already seen the normal lateral epicondyle, so you can see under ultrasound as well. But remember, in some cases, there could not be pain might be there at early phases, but there could not be any ultrasound findings. That is also possible. And differential diagnosis includes the radial tunnel syndrome, cervical radiculopathy, or arthritis. So these are the common differential diagnosis that we have to remember. Let's go for the lateral epicondylitis. So what are the changes in the lateral epicondyle? So first change that we might see in the lateral epicondylitis is that there is change in echogenicity. First of all, in all tendinopathies, this is one of the common feature. So what will happen, instead of normal fibrillar appearance, it will appear hypoechoic in certain areas. For example, in this area, it looks hypoechoic. So you can check in the longitudinal view as well as in the transverse view. Seeing in the both views is important, especially at this area, because here the tendons are changing its angle near its insertion. So what might happen, in certain cases the anisotrophy might be there, you might have been mistaken it as a lateral epicondylitis. That is why it is very important to check in the two areas. First of all, you toggle the probe to see whether there is anisotrophy or not. you try to see from a different angle going closer to the wrist. That is another way. And the third way is checking the same structure in a 90-degree angle. That means we'll be, if you're in a long axis view, go to the short axis view. So in short axis view also you will be able to see those changes. So that is actually signifies that here is the problem. That is very, very important, because it happens in multiple times, that when seen from one angle you might be missing it. Next, coming to the calcific tendinopathy, it means mainly the calcific lateral epicondylitis. So what is this? Basically it's the calcification within the common extensor tendon. So if there is a dense calcification like this, it can be seen under the X-ray as well. Okay, so it is the calcific lateral epicondylitis, and there could be a small tear near the attachment, so that can also be seen in the lateral epicondyle, and it is a, here in this picture it is a full thickness rupture. So up to this part everything is there, and next we are having the hypoechoic area, and this is also reduced in breadth. So basically this is a complete tear of the common extensor tendon. So these are the pathologies that might be there. If you come to the treatment, first of all, definitely in early phases of the lateral epicondylitis, in fact more than 50% of the cases will be treated by the conservative measures, for example rest, activity modification, NSAIDs, etc. So this is the common treatment, and remember in most of the cases this is usually good for the treatment. Now next comes to the physical therapy. Obviously exercise, stretching, forearm muscle conditioning. So these are the common techniques by which lateral epicondylitis is treated if the only conservative management is not working. So it's also a part of the conservative management. Third is the bracing, that is it is to reduce the tendon stress, and in cases we might have to inject the corticosteroid and platelet-rich plasma for the persistent pain. Usually if it is an acute or subacute case, we go for the corticosteroid injection, being careful not to inject within the tendon. So where we can inject around the tendon, but as at this area the tendon is very superficial, so sometimes we give a little around the tendon, and sometimes we go into the muscle part and inject close to the muscular part of the common extensor tendon as well. So basically within the extensor carpi radialis brevis. Remember, in the tendinous part we should not be doing any injection of the corticosteroid, whereas the PRP is the nowadays commonly done treatment, and where injected is usually injected within the tendon, and surgery like the debridement and repair, sometimes release, might be required for the lateral epicondylitis in very rare cases. So it's a video showing the injection of the platelet-rich plasma within the tendon. So tenotomy is being done first, and then injection is being given. Okay. So what is tenotomy? It is the first passing the needle 15 to 20 times in the affected area. It actually accelerates the healing of the tendon. Okay. There is another image, but again PRP is injected within the lateral epicondyle, within the common extensor tendon, close to the lateral epicondyle, and with multiple passes as well. Okay, this aims to heal the tendon in the lateral epicondylitis. Okay, this is one of the most common procedures done in the musculoskeletal ultrasound. Now prognosis, recovery time, most patients recover over several weeks or months with proper treatment, and preventive strategies like the warm-up exercises, correct sport technique, ergonomics adjustment, work and gradual increase in the training intensity that might be required, and long-term outlook is favorable prognosis when addressed early and rehabilitated properly. Now coming to the lateral ulnar collateral ligament injury. Why this ligament is important? Now we have discussed about the lateral collateral ligament, but remember lateral collateral ligament complex includes 4 distinct ligaments. One, definitely the lateral collateral ligament that we have seen, that is from the humerus to the radial head. Then we have the annular ligament which is covering into the anterior part, and we have another small portion anteriorly which is known as the accessory lateral collateral ligament. Then from the base of the ulna, another ligament goes up to the lateral epicondyle, that is known as the lateral ulnar collateral ligament. So what is the importance of this ligament? So previously we have seen the ligament going to the lateral collateral ligament portion. So this can be injured as well, but when this ligament is actually injured in the lateral collateral ligament complex, this ligament is very important because it causes instability. And in a number of cases, if this ligament is not diagnosed, that this injury is not diagnosed, sometimes what might happen, even after a release of this tendon, so collateral epicondyle, then what will happen that in case of surgeries, that tear may lead to the failed conservative treatment or the lateral epicondyle that is in the chronic instability phase as well. So what is the injury? It is the same overuse forces that has damaged the common extensor tendon can also affect the lateral collateral ligament and also. And if a lateral collateral ligament is missed, and surgical release of the common extensor tendon actually can worsen the symptoms and increase the rotator instability. And routine LUCL evaluation in patients with the lateral epicondylitis is also very important. Okay. And there could be tendon with the whole complex, or there could be injury into the deepest fibers of the common extensor tendon origin as well. So we have to examine it, and also if required in early injuries PRP injection can be performed, but in advanced cases it requires a surgery. In pulled elbow also this can happen in children. So while you are getting those cases, usually as a pain physician we don't get such children cases, but if you go to those cases you have to check for the lateral ulnar collateral ligament as well. Now coming to the radial tunnel syndrome and supinator syndrome, so it is basically the same. So what happens in the lateral part of the elbow is that here we have already seen in between two layers of the supinator, the nerve goes is the radial nerve. So one part goes just above it and one part goes inside it. So what might happen? So there could be entrapment neuropathy of the radial nerve, especially in the posterior interosseous nerve in the forearm. So it entrapped typically around the proximal forearm near the radial head. So it can cause pain, and here the pain, instead of where in the lateral epicondylitis was mostly nociceptive pain, now it will become a little more neuropathic pain with the neuropathic senses, and it will go slightly anterior towards the forearm as well. Now radial nerve divides into superficial branch, which is sensory, and a posterior interosseous nerve, which is motor around the elbow, and sites of compression is the fibrous band in the radial tunnel near the supinator muscle or around the thickened fascia. Results in the pain primarily due to the nerve irritation, which lays emphasis on the motor deficit compared to the posterior interosseous nerve syndrome. So when it is compressing mainly close to the elbow joint, it is mainly compressing the main nerve trunk, and that usually causes more sensory symptom and less motor symptom, where the compression within the supinator muscle or while exiting from the supinator muscle, it is actually compressing more on the posterior interosseous nerve. So what are the risk factors? So risk factors includes the repetitive forearm movements like excessive wrist and finger extension and supination. Occupational includes the manual labor, sometimes the assembly line work or repetitive lifting, and sports related like activities involving repeated forceful forearm rotation and trauma, direct contusion of the fracture around the radial head. Now, clinical presentation is usually associated with the pain, which is deep aching pain in the lateral forearm, just distal to the lateral epicondyle. But one of the important feature is the tenderness over the radial tunnel, often misdiagnosed as the lateral epicondylitis, and also the nature of the pain is one of the things that you should consider. Though in case of chronic lateral epicondylitis, sometimes it can get some neuropathic character or mixed character, but in purely radial tunnel syndrome, it is mainly neuropathic pain rather than a nociceptive pain. Aggravating factors includes the registered supination or middle finger extension, because this actually puts more pressure over the supinator and that can increase the compression over the nerve. And usually what happens, unlike the radial tunnel nerve pain, it is compressing on the posterior interosseous nerve. It is mainly because causing motor symptoms, and when it is compressed in the proximal side, it is mainly causes the sensory symptoms. And diagnosis is based on the physical examination like registered supination test or registered middle finger extension test, palpation of the radial tunnel region, and differential diagnosis is definitely the tennis elbow. And sometimes the cervical radiculopathy, especially the C6 radiculopathy, sometimes be confused with the radial tunnel syndrome. And imaging includes definitely the electrophysiology that can diagnose this condition, and also MRI or ultrasound if there are any structural abnormalities seen at this area. So let us see first under the ultrasound how it looks, the radial nerve, and we'll be seeing in the both cross-sectional and the longitudinal manner. And if it is happening, there is a compression, so bottlenecking is also seen. There will be a dilatation neuroma at the site of compression. Chinmay, please go for the demonstration.
Okay, so I will show the radial nerve, and this is also associated with the artery. I mean, recurrent radial artery is there, but mainly the radial nerve and its branches. So I will again start from the home page view. So this is the home page view. So what we are seeing here, I will freeze it. Okay. So this side is lateral side. This side is medial side. Number 1. Which muscle is this? Anyone?
Brachioradialis.
Brachioradialis.
Okay. Number 2.
Brachialis.
Brachialis. Now, this black line. What is this black line?
Uh,
Cartilage articular surface.
articulus.
Yes. This is articular cartilage. Okay. So sometimes here there is one line of, I mean, aponeurotic line is there, but don't confuse that this part is brachioradialis and this is brachialis, nothing like that, because brachialis also has lateral fibers and medial fibers. So this part is lateral fibers and this part is medial fibers anyway. So here we will target. Yes.
This brachialis looks diseased, or it's normal.
No, it is normal, because this elbow, you cannot make it completely extended sometimes due to the, and anisotropy is common in elbow. Okay, so I can remove the anisotropy of one part, but then another part anisotropy will come. But in elbow ultrasound, most of the time you will see the anisotropy. So, okay, this part is now our point of concern. We will see the radial nerve here and also associated recurrent radial artery and vein. Okay. So, as at present, this picture is just in the lower end of the humerus. So, this is in the lower end of the humerus. Okay. So, now this side, I am going a bit distally. So, you can see that this is the nerve. This is the nerve, radial nerve. Okay. So, this is undivided radial nerve. From here, actually, the PIN, posterior interosseous nerve will come, and deep branch and superficial branch will come. So, this is the radial nerve. Here, if I give some color, something should come. Okay, later I will see. If I go down, I will of course see the color. So this is a artery. This is a artery. Anyway, so this is the lower end. I am going gradually down. So this is the joint area, and this part. As soon as I see the rounded structure, so just a minute. So this is the humeral end, joint area, and this is the radial head. This is the radial head. as soon as I see the radial head, I will try to see the supinator also. So this area, okay, mainly. So this area is the supinator. Okay, as soon as I have seen, so this was the radial head. This is the just round structure radial head I have seen. Just above that, this is the supinator. So at present, I know that this is the radial nerve and this is the supinator. So it is obvious that this will enter within the supinator. So here I will just change the position of the hand, like I will pronate the hand. I will do some pronation. Okay, so now again, so with this pronation, I can see the supinator in a much better way. Okay, so this part is supinator. This picture is not really nice. Just a minute. Okay. Okay, anyway, so this is the radial nerve, and this is the radial head, and this is the supinator. So within the supinator, you can see one white line. This is just this is the white line within the supinator muscle. So this white line is nothing but the tip branch of the radial nerve. So if I see in a long axis view, just a minute. Okay. Actually, this probe doesn't have that much power to show you the nerve very nicely. But this is the supinator muscle. This is the radial head, neck, and this area is the supinator muscle. Within the supinator muscle, this is the deep branch of radial nerve, deep branch. This part is supinator. This is the deep branch. This is the superficial branch, and this is the complete radial nerve. Upper part is the complete radial nerve. This is the branching. Okay, let's see again. Cranial side is left side. So I am seeing here just over the radius. So this is the deep branch. This is the deep branch of radial nerve, and upper part is the superficial branch. This part is the superficial branch, and this is the deep branch. If I make it in a short axis, then it is inside. This is the deep branch inside, but it is so this is the radial nerve inside. So here this part is the complete radial nerve. This part is the complete radial nerve. Here, from here, the separation is not very clear, but this is the deep nerve. Okay, this is the deep nerve. Here with this probe, I cannot show better than that. Next day, when we will use the high frequency probe, then we will show again this part. Okay, but you understand that within this supinator, as soon as you see the radial head, you see the supinator. Within the supinator, you see the deep branch, and above the supinator, we see the superficial branch. Superficial branch is very tiny, basically the deep branch. So at this point, at this point, as soon as when the head comes, head of radius appears, as at this point the deep branch enters in the supinator, and then we make the hand a bit prone, and we can see the deep branch. This is the deep branch, and it enters and it comes out of the supinator as soon as we go a bit distal. So within this area, that is the area for entrapment. Okay, so this is the deep branch. Okay, so it is going like this and it is coming out. So this is the deep branch. In this area is for the entrapment. Okay. Don't you think?
Yes, I'm here. So let's continue. So what are the treatment options? First of all, definitely, here I will not be repeating, I think, because most of the initial part of the treatment is the same. So go for the conservative management and physical therapy. Then if it is not responding, either you can go for the corticosteroid injection for localized relief, but what we commonly do is the ultrasound guided hydrodissection. So it is basically a minimally invasive procedure where fluid, sometimes saline with a little bit of the steroid, and most of the cases it's the 5% dextrose that is injected around the entrapped nerve to separate it from the adhesions. There are studies, people have done it with the platelet-rich plasma as well. So it helps the patients to recover continuously, and most of the patients respond favorably to the conservative management over weeks or months. Surgical decompression is required only in case of persistent cases which are unresponsive to the conservative management. And preventive measures include the ergonomic modifications, proper warm-up, and the gradual progression of the activities so that it is not compressed. Now coming to the area where it is compressing within the supinator or at the entry of the supinator, there is a fibrous arch at this point where it is entering the supinator. It is known as the arcade of Froche, and this is the common area of compression of this nerve. So remember, when it is happening just exit of this radial tunnel, then at this point it is giving mostly sensory symptoms. But when it is compressing at this point where already the posterior interosseous nerve is formed and it is entrapped, then it gives mostly the motor weakness of the muscles. So this is known as the posterior interosseous syndrome, and it's a form of the radial tunnel syndrome, and also it is known as the supinator syndrome. So etiology, as I told about the arcade of Froche, it is a fibrous arch that can entrap or tether the posterior interosseous nerve, and here also along with the tethering there will be the dilatation of the posterior interosseous nerve, and there will be fibrous band and vessels sometimes may be there that will compressing the nerve, and there are causes that can be seen under ultrasound. For example, soft tissue masses like the periosteal lipomas or some deep ganglia or some scar tissue from trauma like that from radial head fracture that can also displace and compress the nerve, and fracture dislocations like Montague fracture or malaligned radial head or neck fracture that can also cause the pin with the callus formation. Now, how the patient presents? Remember, here mostly the things happens in the metacarpophalangeal joint. So, basically it is the finger drops and the weakness in the finger extension of the metacarpophalangeal joint. Thumb also cannot be extended or cannot be abducted because of the extensor pollicis longus and the abductor pollicis longus involvement. Whereas the wrist extension is usually spared because while it is going to the supinator, already the extensor carpi radialis longus and brevis is given, so they remains functional. So wrist extension usually remains, and there will be pain and tenderness that can also mimic the resistant lateral epicondylitis with a little bit of neuropathic component, which is more. That is how it is differentiated. So what is required? It requires the high resolution ultrasound. It can visualize the swollen hypoechoic proximal interosseous nerve involvement and within the supinator muscle. So you have to see in the longitudinal view to find out the dilatation, and also in the cross-sectional view we have to find out the dilatation at this point. Okay, and if there are cause can be found, for example, if there is a mass that is compressing, that can also be seen under the ultrasound, and thickened or thin nerve segments that also indicate the possible stitching injury. And clinical test is usually the registered supination test or the middle finger extension test, and MRI is useful in detecting soft tissue masses and confirming the nerve entrapment when ultrasound findings are not very clear. Now coming to the management. In the conservative management, so we have the conservative management, hydrodissection and surgical decompression in this area. So let's see hydrodissection for the radial nerve. So here in the short axis view, in between two layers of the supinator, the needle is passed close to the posterior interosseous nerve, and here first we'll be injecting at the top of the nerve, and then we'll be going below the nerve to produce a halo around the nerve. Okay, management is similar here. Here also we have to go first at the top, and then we have to come below and around the nerve for the proper decompression. And last day someone asked the question that where should we do decompression? At the dilatation, distal to the dilatation, proximal to the dilatation? Can anyone tell where actually we do the dilatation?
Proximal to the dilatation.
So it is actually at the compression zone. Okay, remember where it is compressed, what we do actually is the compression zone, and compression zone is usually distal to the dilatation in most of the cases. Okay, so we have to do the dilatation at the compression zone. That is the most important thing. Okay, because the exoplasmic flow is hampered, that is why there is the formation of the dilatation. Now coming to the last portion of it, that is the posterior part of the elbow. So posterior elbow, it is the olecranon bursitis. Sometimes there could be snapping triceps syndrome and the triceps tendinopathy, and posterior elbow impingement as well. So what is student's elbow? It is basically a subcutaneous bursa which remains near the tip of the olecranon process, and repeated fracture causes bursitis and accumulation of fluid at the bursa. So it is known as the student's elbow and occurs in the elbow tip, and function of this bursa is to reduce the friction between the soft tissue and the bone, facilitating the smooth movement around the joint. Okay, and here repetitive pressure causes that condition. So trauma could be one possible cause, infection sometimes could be a possible cause, and inflammatory conditions like gout or rheumatoid arthritis can predispose to this bursitis. Clinical presentation, there will be swelling and redness which is noticeable enlargement over the posterior elbow, and sometimes there could be redness and warmth might be there, and the pain and tenderness can be mild to severe, aggravated by the bending the elbow or direct pressure over that area, and there is reduced range of motion, and signs of infection could be there if the infection is there. So let's see the posterior elbow portion.
Okay, so I will show the posterior side. Okay. So I'll show the posterior side of the elbow. So here, posterior part of the elbow is quite easy. It is only one muscle, that is the triceps muscle, with three heads: medial head, the long head, and lateral head. And though it is name is medial head, but while it is making the tendon, it comes in the midline. So just understand that medial head is actually making the middle head, and then long head is medial side and lateral head is lateral side. Okay, then I'm showing you the tendon in a long axis view. So this is the way I'm holding. So what I can see here is the humerus. First I'm showing you the humerus, posterior side. Okay. Okay. Hmm. Yes. Uh, no. Posterior side. So this is the olecranon fossa. This is the joint. Okay. This part is the olecranon. So when I move the olecranon, when it is completely extended, then these olecranon will come and take in this area. It will enter in this fossa. Okay. So above that, this is the triceps tendon. This is the triceps tendon. So triceps tendon insertion is not exactly on the tip of the olecranon. It is a bit 1 centimeter below the tip of the olecranon. So you can see that. And this part is fat. This is fat. This is fat. And this is looks like that there is some tear or something, but it is actually anisotropy. Okay, so I will show it. So you can see with movement, just so we can see the olecranon processes come inside the fossa. Now, if I do extension, flexion, it goes out. Okay. And when I see the tendon, you can see the above tendon up to its insertion. So insertion is not at the tip, at a bit below than the tip. So you have to check up to this area to see any insertional tendinopathy. Okay. This is the area for any insertional tendinopathy for seeing this area. Okay. And if there is a effusion in the joint, say in this area, there is a effusion in the joint, then you have to see this fossa. You have to see this fossa. So if there is a fluid, it will displace this fat upward and you will see the hypoechoic fluid here. Okay. As you can see that with the different position of my probe, the tendon becomes normal of normal consistency. I mean, it is hyperechoic tendon. You can see hyperechoic fibrillary. It is not a, I mean, not, it is only an anisotropy. It is not that there is any tear or anything. Okay. Now I am showing you the short axis. So here, left side. So here also, this is the lower part of the humerus. Okay. If I go a bit down, so this is the olecranon fossa, and this part is the fat part. This is all fat part. Now tendon should be forming here. Here in triceps tendon, this tendon doesn't form exactly in the midline. Okay. Here, this left side is medial side and right side is lateral side. Okay, this side is lateral, this side is medial side. So when I'm coming down like this, you will see that this is the tendon formation. This area is the tendon formation. If I go a bit up, then there are two tendons actually. These tendons are not completely same. So here one tendon, comes from the long head, and this tendon is coming from the medial head, and this side is the lateral head. But they form a conjoint tendon in the common tendon. They form a common tendon. So this is the area for formation of the tendon. And as I am coming down, you will see that this tendon and this tendon is coming together. So now I'm showing you the tendon. So this is the tendon and this is over the olecranon. So when over the olecranon, you have to see carefully if there is any tear or anything like that. So this is the olecranon fossa, and now above this is the tendon. This is the tendon formation. This is some part of the lateral head still there. So this is the tendon and this is the area. We have to check this area to see the whole tendon, if there is any tear or anything like that. This tendon has, it looks like two parts. So this part comes from the this long head, and this is the medial head. But this is ultimately the same tendon. So up to this much we will check, and then we can go up to see the different muscle heads. So this is the area for triceps, seeing the triceps tendon. Okay.
Okay, so let's continue.
Yes.
So how we should diagnose? First of all, physical examination. So that is most important, because inspection of the posterior elbow for the swelling, and it is usually a very as the fluid is very superficial, you can see a very superficial swelling along with the redness and tenderness. And in some cases we can go for the aspiration of the fluid, and we can go for the routine examination and microscopic examination as well for the pistol-induced arthritis, infection or gout. And in imaging, we can go for the X-ray to exclude the fracture and bony abnormalities. And ultrasound and MRI is very good because it's a very superficial structure. Ultrasound is also very good here. You can see the chronic traumatic olecranon bursitis that is being seen under the ultrasound. Here you can see the fluid at a very superficial level. So it usually is clinical. Ultrasound we can do, we can check, we can aspirate under the ultrasound, but usually only for the diagnosis. Even ultrasound is not required. You can see that area, but ultrasound can be very well able to make you differentiate whether there is a bony fracture underlying or not. That we can see with the ultrasound. And treatment, first of all, it comes to the conservative. Then we can go for the aspiration under the ultrasound guidance. We can do the corticosteroid injection post aspiration, and in septic cases we can go for the antibiotic treatment as well. And definitely in certain cases when it is recurrent, we can go for the surgical excision as well. Prognosis is usually favorable for most of the patient and results with the continued conservative treatment and the lifestyle adjustment. And preventive measures include avoiding the hard surfaces or prolonged elbow contact, use protective padding during the activities prone to the cause the elbow trauma, and prompt treatment of any elbow cuts or abrasions to reduce the infection risk. Next, coming to the snapping triceps syndrome, where the triceps fibers actually comes close to the medial epicondyle, and that cause a clicking syndrome. So it is basically anterior dislocation of the medial head of the triceps muscle over the medial epicondyle, and which causes a snap that occur during the elbow flexion, reflecting the ulnar nerve dislocation and the medial head of the triceps. So there could be medial elbow pain and a snapping sensation, and also sometimes that cause ulnar neuropathy, and its cause is not really known or unclear. The possible contributors includes abnormal origin or hypertrophy of the triceps muscle. Sometimes it can be caused due to the post-traumatic bony abnormalities like altered anatomy from fractures, and congenital or acquired changes that allow the muscles of the nerves to shift over to the medial epicondyle and scratch over during the flexion and extension. So what we can see in the dynamic ultrasound imaging that the muscle and the nerve displacement during the active elbow flexion and extension and palpation to feel to distinct snaps over the medial elbow. And conservative is usually the activity modification, bracing, physical therapy, and in some cases we might require the treatment under the surgery. Okay, next here it is an image of the triceps tear. So in the posterior elbow there could be a tear in the triceps as well, a small tear within the fibers of the triceps can be seen at this point. Okay, so we have to examine for that also. And also another pathology is the posterior elbow impingement, where soft tissues or bony structures in the posterior aspect of the elbow become compressed during the elbow extension, causing pain and reduced range of motion. And it can be caused by the repetitive hyperextension. Sometimes it can be caused by the bony spars or osteophytes, along with the degenerative changes that can produce bone growth and irritate the soft tissues, and there could be possible loose bodies at this point as well. And what happens in the impingement of the posterior elbow? There is pain and stiffness at the back of the elbow, especially near the full extension. There could be possible locking and catching or clicking sensation, tenderness over the olecranon tip or fossa, and physical examination which tests the pain provocation on the terminal extension. And also imaging helps in diagnosing if bony growth is present. And treatment initially conservative, then we can go for the ultrasound guided corticosteroid injection. If there is fluid in the olecranon process, that we can aspirate under the ultrasound as well, and then we can go for the corticosteroid injection. And in some cases we might require arthroscopic debridement at that area. So here it is showing a posterior joint effusion that can cause also a impingement while this is going at this area, so it will be painful because of the effusion at this joint. So that covers the most common disorders at the posterior elbow and also the lateral elbow. So these are the diseases, and this you have to diagnose under ultrasound, and even without ultrasound also, and you have to treat. So any questions? Okay, let's go for the quiz. Yes, someone is asking something. Yes.
Yeah, regarding if there is joint effusion and we want to inject steroid, the
Yes.
only approach is through the posterior joint.
No, it depends on which joint is involved. If the radiocapitular joint is involved, we should be going from the anterior side. If it is the ulnotrochlear joint is involved, then also we'll be going for the anterior side. If the olecranon area is involved, then we'll be going for the posterior side.
Okay, so we can go through the
We
anterior.
can check under where in which side we can see the effusion. So based on that, we can change our plan.
But
And yes, elbow is a superficial joint, so it doesn't cause any problem from which side you go. You just avoid the vital structures and go. That's all.
Okay, thank you, doctor.
Okay, let's go to the quiz.com.
Love Street. Kama. Lucky.
Let's join.
House King. Foolish House. Captain Slow.
Okay, let's start.
Quiz.com. Play and create.
Which tendon is most commonly involved in lateral epicondylitis, tennis elbow? Extensor carpi radialis brevis. Which structure is primarily responsible for lateral elbow stability? Lateral collateral ligament complex, including the luteal. In radial tunnel syndrome, which branch of the radial nerve is typically compressed? deep branch, posterior interosseous nerve. Which clinical test commonly helps differentiate radial tunnel syndrome from lateral epicondyle? Resisted supination or middle finger extension test. Which fracture is most commonly associated with acute lateral elbow pain following a fall on an outstretched hand? Radial head fracture. Which condition, often called student's elbow, causes swelling and tenderness at the tip of the elbow, posterior? Olecranon bursitis. What is the primary mechanism leading to posterior impingement syndrome in overhead athletes? Repeated hyperextension of the elbow. Snapping of the triceps muscle with concurrent ulnar nerve dislocation at the elbow is known as snapping triceps syndrome. A full thickness tear involving both the lateral ulnar collateral ligament and the common extensor tendon could lead to posterolateral rotatory instability.
Final question. Double points.
Which of the following is a typical finding in triceps tendinopathy affecting the posterior elbow? Discomfort at the triceps insertion worsened by resisted elbow extension.
Third place. Lucky. Second place. House King. And the winner is Foolish House.
So who is Foolish House? Who is foolish house? No one is saying. Okay, congratulations. So let's end this. Okay, so we'll meet in the next class. Let's end for today.